So we are here today for a very special program called Understanding More About Multiple Sclerosis and the Treatment Options that are Available. And we have an esteemed speaker here today. We got Dr. Aaron Boster. A lot of you all know him that are in the audience right here, as well as those that are online. I'm sure he's still clicking in, but I got to say hello and, give everybody the applause that they need. So speaking about applause, let's welcome and thank our sponsors for today's program. We got Sanofi and Novartis. Can everybody give them a round of applause, please? Thank you. We also got a community sponsor named TG Therapeutics, and we should give them a round of applause as well. They did a good job making sure we could do this program. So let's get started so that way we can get this program underway. Dr. Boster has to go to bed early.
I've traveled around the world teaching people about multiple sclerosis. That always works no matter where I am. It makes me really happy. Have any of you not been subjected to me before? Oh, great. Wonderful. Well, it's nice to see you again. So I am delighted to be here today to talk to you, sponsored by MS Views News. Can we give them a round of applause? This organization, in my opinion, leads the way in MS patient advocacy and education. And throughout the entire pandemic and after this pandemic, they have persisted in coming to all different parts of the United States and finding guys and gals like me to help up your game. And I think that's really, really special. So thank you guys for supporting us tonight and being here. They asked me to talk to you about a list of things relevant in MS. And as I was reading through it today, in between patients, I really think that the way I would like to frame our discussion is as follows. We have a singular goal, in my opinion, as we try to combat having multiple sclerosis. And that's to make the disease as boring as possible, right? Can you get behind that idea? That we want to make MS as boring as possible. Otherwise stated, I want you to live your best life despite having MS. Is that fair? Now, I didn't say things like we're going to cure you for a limited time only for $9.99. If you sign up now, you're going to fly. I said I want to make you the best version of you possible despite having this condition, and I want to make it boring. And I'm going to go over a rubric for how to do that in about 45 minutes. It was really funny when Stuart said 35. Several people in the audience that knew me said, you can't talk that fast. So I'm going to share with you how I would like to approach making MS boring. And I'm going to do it in the context of being 5 for 5 in your fight against MS. And I'm going to need your help, the folks in the audience, to do that. When I say 5 for, I want you to scream 5. All right, so we're just going to practice really quick. I want you to be 5 for 5 in your fight against MS. And that's going to be a theme that we're going to keep as we talk about this. There are 5 things that I want you to do to live your best life. I want to point out that 4 of them I can't help you with. I can educate, I can empower, I can energize, but I need you to drive 4 of the 5. The 5th one is going to be where we're really going to liaise in clinic, where I'm really going to work with you as a partner, all right? So number 1 in our fight to be 5 for 5. Oh yeah, that was fantastic, is to not smoke stuff. Right, what do you mean not smoke stuff, Aaron? Smoking increases the risk to develop MS by double. People who smoke are twice as likely to develop multiple sclerosis compared to those that don't. That's a fact. And even secondhand smoke can increase the risk to develop MS. Now, I've never met a Midwestern parent that tells their kid, smoke up, Johnny. But nonetheless, there's plenty of people that still smoke plenty of cigarettes. And smoking or being exposed to secondhand smoke can increase that risk. And as a parent, I want other parents to be aware of that. And if you have MS, it speeds up your disease by about 50%. Allow me to repeat. If you smoke cigarettes, it speeds up your MS by 50%, which is pretty remarkable. In the ancient days of yesteryear, the old school medicines to slow down MS could slow it down by 30%. Quitting smoking slows it down by 50%. There's actually a bigger effect size by not smoking. Now, you noticed I said don't smoke stuff. For those of you that drove over here, you passed by a dispensary of the medical cannabis, on your way over here. All right. And I am a recommender in the great state of Ohio for medical cannabis. And I think that there's a lot of value for MS symptoms, but I don't want you to roll it up into a blunt and smoke it. I don't want you to light cannabis on fire and suck in the smoke for the exact same reason I don't want you to smoke tobacco, because it's pro-inflammatory, all right? So number one, in being 5'4", you don't miss a beat, hoorah. And fighting MS is to not smoke stuff. And in fact, I want to extend that conversation, because any cardiovascular risk factor can make your brain arteries, the vessels in your brain, get harder faster, make your brain shrink faster, and actually make your MS get worse. So it's not just smoking. Any other cardiovascular risk factor, morbid obesity, inactivity, high cholesterol, high blood pressure, thanks mom and dad, all of these kind of things can increase the speed at which you get worse, which simply means as we're gaming out how to live your best life despite having MS, one of the things we need to do is pay attention to brain health. As I shared earlier, I can't make you do that. Now, in full transparency, I can't make my son hang up his towel in his bathroom. My son just graduated high school. He's 18 years old, and he still leaves his towel on the floor, and the cat pees on the towel, which is disgusting. And I said, Max, for the love of all that's holy, he can't pick his towel. So I can't make you stop smoking, but I can educate you about why I think that's a grand idea. Is that fair? Now, number two, in being 5'4", and your fight against, I love that so very much, 5'4", in your fight against MS, is to exercise as part of your lifestyle. Now, what does it mean when you do something as part of your lifestyle? That means that it's woven in the fabric of your week. You don't get punished when you don't do it, and you're not rewarded when you do it. Okay. So if you are in the military and you choose not to exercise, they'll lock you up in jail. That's not part of your lifestyle. That's not like something you get to do. When you do something as part of your lifestyle, it's just part of, and I'll give you an example. I have a lifestyle of showering in the morning. You're welcome, right? So I just take a shower as part of my morning routine. If for some reason I couldn't get a shower in the morning, I wouldn't freak out and like text message people and call off work. I would just try to put my hair up in a bun and go in, and I would shower when I get home from work. No big deal. Why are you laughing at that, young lady? And so that's part of my lifestyle, taking a shower. I need you to have exercise as part of your lifestyle. So it's hard to exercise with MS, and yet the reality is people impacted by MS who exercise as part of their lifestyle are less disabled at the end of their life compared to those that don't. Very simple fact. I want to give you a quick thought experiment. So we're going to have to get permission from your significant other, but let's just pretend we could clone you. Woo, now there's two of you. So with consent, we're going to make two of you. Okay, and we're going to give one of you Days of Our Lives TV and chocolate cake, and we're going to give the other an elliptical. And we'll get back together in a couple years, and we're going to find two versions of you. We're going to find one version who has been exercising, has a strong core. All right, they've got strong legs, cardiovascular endurance is pretty solid, balance is a little bit better. They got their groove on, look a little bit like a Greek goddess. And then the other version of you found the weight that the first one lost, okay? And they're a little out of shape, a little heavy. All right, the balance is not very good, but they know a lot about TV. All right, there's two versions of you. And then you're both going to suffer an attack of left leg weakness. She who's been exercising is limping around the house, pissed off, doing some physical therapy, working full time, recovering. The other version of you is trapped in a wheelchair. And I'm not going to ask you the rhetorical question of which one you want to be. I'm just trying to make a point that we have to commit to a lifestyle of exercise if we want to live our best life despite MS. Exercise arguably is the least appreciated form of disease-modifying therapy to slow the disease down. And I can show you time and time again, when people commit to exercise, spasticity is better, balance is better, bowel and bladder is better, sex is better. There's a lot of things that improve when people embrace exercise as part of their lifestyle. Now, it's not easy to do that. It's not easy to, and so let me give you like 3 quick tips. Number 1, if you're having trouble getting your exercise on, I want you to talk to your neurologist about hooking up with a neurophysical therapist. Neurophysical therapists are wizards. They look like humans, but they're not. They wear scrubs. And they're wizards to help you figure out how to exercise as part of your lifestyle. They're really, really good at it. And so if you're having trouble trying to figure out how to get your groove on, that's a great way to do it. Second tip, water is magic in the setting of MS. In water, you weigh less. So that weak leg that can't support your weight very easily, you can crush it when you're in the water because you weigh less. If your balance is off and you fall to the left, the water pushes back to the right. So that's pretty awesome. If you have heat sensitivity, as many of my patients do, the water wicks away the heat. And so water is a fantastic way of exercising. Another thing that I want to keep in mind is that exercising seated or with your walker, there's no shame in that game. There's an awesome series of things that one can do. You don't have to be a college athlete to raise your heart rate. You don't have to be fully ambulatory to live your best life. So number 2, in your goal of being 5'4", that was a little on the slow side, yo. All right, so I just want to keep you on your toes and be honest with you. So number 2 in being 5'4" is to exercise as part of your lifestyle. Now, number 3 is to eat smart. All right, so let's talk about eating smart. I hate it when doctors say dumb stuff. Things like eat whatever you want, it doesn't matter, because that's false, right? What you eat absolutely has an impact on your lifestyle and absolutely has an impact on MS symptoms. And what you eat can have a really, really big impact in your quality of life and what goes on with your MS. Now, this is actually a really, really big conversation, but we're just going to kind of start to talk about it very briefly. Show of hands if you knew that eating ultra-processed food speeds up your MS disease process. Raise your hand. So I'm impressed. There's about half the people in the room that have heard about that before. So I want you to eat foods which you learned how to pronounce when you were like 3 and learned how to spell in the 2nd grade, right? If you ask a 2nd grader, they knew all the food words: broccoli, chicken, fish, potato. Those are food words. If you look at some ingredients and you can't pronounce the word, methylcarba hoobity hobbity, that's not a food, that's a chemical, and I don't want you to eat that, all right? And that's a tip-off that it's an ultra-processed food. So I really ask my patients who want to live their best life despite having MS to avoid fried foods, sugar-laden foods, diet foods, fast foods, and foods with ingredients that you can't pronounce. Now, that's very hard to do because ultra-processed foods, they taste good and they're readily available and they're inexpensive. And so here's my challenge to you. I want you once a day to identify something as ultra-processed and not eat it. Not everything you're going to eat, but I want you to identify one thing that's ultra-processed and set it aside. I'll tell you a little secret. When I was, years ago, many of you worked with me when I was at the Ohio State University. And back then, I used to live on Diet 7-Up. I thought it was delicious. Diet 7-Up was the jam. And I would literally go through like 6 or 7 Diet 7-Ups in a day. I didn't realize what I was doing to my body. And what I've done now is I replaced Diet 7-Up with sparkling water. And I have this little machine at my house. It's awesome. It's got a CO2 and I press a button, it goes, and then it makes it carbonated. And I put a little lemon in it and it's delicious. All right, so I have replaced an ultra-processed food with a form of carbonated water that is the jam. All right, so I want you to pick one food each day and say, well, that's I'm not gonna choose not to have that, right? And most non-ultra-processed foods are gonna be things that you already know about. They don't need to be in packages. There's things like an apple. If you're trying to up your game and live your best life and you wanna try to eat smart, one way to do that is to up your water game. Right? What do I mean by up your water game? Most red-blooded Americans run around super dehydrated. And when you have MS, a lot of people with MS have bladder problems, where when they got to go right now, and they can have an accident if they don't get there in time. This is very, very real. I hear about this in clinic all the time. And so a lot of people with the very best of intentions, they take the wrong approach. They say, okay, well, if I have a risk of bladder accidents, I just won't drink anything, because then if I don't drink anything, I won't make urine. Well, physiologically, that's actually not accurate. You'll still make urine. As long as you have blood volume, you'll make urine. It's really, really concentrated urine. That's why when you pee, it's like dark color. That urine is full of toxins, which is very irritating to the bladder wall. Guess what it makes the bladder do? It makes the bladder spasm down. All right, it makes you have a little tight racquetball bladder that can't hold very much urine. When you drink a lot of water, you flush that bladder out. You're constantly flushing it out. The color of your urine is clear. All right, and it's much less irritating to the bladder. Also, when you don't drink very much and you have a lot of concentrated urine, that's a great place for bacteria to live. If you take a cup and set it there and put urine in it, put it on the windowsill and come back in a few days, it's going to have bacteria in it. that can happen in your bladder. And by drinking lots of water, you flush all that out. So upping your water game is really where it's at. Now, how do you up your water game? I'm looking for you to drink at least 68 ounces of fluid, upwards of 100 ounces of fluid a day. And that ain't easy, all right? I'll be honest, I've been working on that, and I'm getting better and better at it. Here's the quick tip. However many meals you eat each day, add a glass of water. You pick the size. Now, I'm tricking you because I'll make the size bigger later, all right? But if you're gonna have breakfast, you're gonna have bacon, eggs, toast, orange juice, coffee, glass of water. For lunch, you're gonna have Aaron's favorite lunch. You're gonna have a cheeseburger and French fries, I'm teasing, and then a beer and a glass of water, all right? My point here is I want you to get used to adding 1 glass of water with each meal. Then all you have to do is add a glass of water between each meal and you're good in the hood. We're gonna up our water game. The second thing I wanna do before I switch topics, the second thing I wanna talk about as it relates to eating smart is to supplement vitamin D. Now, we live in the great state of Ohio where there's not a lot of sun most of the year. And when I check people's vitamin D levels, sometimes it's in the gutter. It's like super, uber duper low, very, very low. And it turns out that in groups of people with MS, low levels of vitamin D drive the disease faster. So having a low level of vitamin D is associated with more attacks, more spots, bad stuff. Higher levels of vitamin D, up above 50, but below 100, that's the sweet spot, that's where we want you. There's 3 ways to get vitamin D. Number 1 is you take your shirt off and you go outside in the full sun for 15 minutes. And you just like hang out there in the sun and you absorb all that vitamin D, which in Ohio would result in 2 things happening. The police officers would come to visit. Yeah, that's right. Your neighbors would call the police and you would get frostbite in places that you don't want it most of the year. So that's probably not viable in Ohio. Another way is to eat fatty fish, and you would have to eat an entire salmon, or the whole fish, about once a day to get enough vitamin D. And that's very hard to do. So most of my patients, I ask them to take a D3 supplement. D3 because it's better absorbed in the human body. So if we're gonna live our best life, as we're gonna try to be 5'4" in your fight against MS, one of the things I need you to do is to eat smart. Number four is to practice daily mindfulness. Show of hands if you have ever heard of mindfulness. Now keep your hands up if you were taught about it in school. Yeah, that's because everyone in this room is like older than 18. And mindfulness is not something that we were taught very much about growing up. I define mindfulness as being in the present moment without prejudice. All right, my joke is that if you're having sex and thinking about work, you're doing it dead wrong. All right, so in order to be mindful, you need to be in the activity, thinking about the activity. You need to be participating in the activity and not worried about what happened yesterday. No. You need to be in the moment. You need to be involved in the activity and not worried about what's going to happen tomorrow. You need to be thinking about now. The reason it's so important to practice mindfulness is because MS is something that we can't get rid of, and stress is something we can't get rid of, and stress makes MS worse. I hate when doctors say dumb stuff like, remove the stress, honey, as if like you could cut it out and be like, oh, I'm better, doctor. That's not realistic. And our lives are rather stressful. So if you have like a husband, you have stress. If you have kids, you have stress. If you have a mortgage, you have stress. Let's be honest. And so learning how to manage stress is something that we are not taught, and yet it can make our MS worse. So practicing daily mindfulness, 5 to 10 minutes a day is all I need. Practicing daily mindfulness is a way to learn stress management. Remember how I told you earlier, I have a lifestyle of showering? Remember? So I added something to my shower during the pandemic. I sit down on the floor of my shower with the water running, I close my eyes, and I go through a breathing exercise. It takes me about 7 minutes. Best part of my day. I do it on purpose when I'm getting ready for work because it slows me down because I'm like running full steam trying to get to my clinic. So it makes me take pause, and it helps get me ready, and it helps emotionally get me ready. I actually wake up a little early just so I have time to do that. Now, that's an example of being mindful. There's other ways to be mindful. Bible study can be mindful. Meditation can be mindful. Yoga can be mindful. Tantric sex can be mindful. Going for a walk in the woods can be mindful. There's a host of things that one can do. I just need you to do 5 minutes a day. I told you that I want you to be 5'4" in your fight against MS. And I said that the first 4 were things that I can't do for you. I need you to do them. I can energize, I can empower, I can educate, but I can't do those things for you, all right? I can't ask you to not smoke. I can ask you, I can't make you not smoke stuff. I can't make you exercise as part of your lifestyle. I can't make you eat smart, all right? I can't make you practice mindfulness. I can just ask that you do that. Now, number 5 is to take the most effective disease-modifying therapy that you're comfortable taking and make sure it's working. Number 5 in your fight against MS, ooh, I tricked you there. I want you to be 5-4 in your fight against MS. And number 5 is to take the most effective disease-modifying therapy that you're comfortable taking and make sure that it's working. And I crafted that sentence very carefully over the last 20 years. When I first started to think about that sentence, I had a full head of hair. Oh my goodness gracious, what's happened? You know, one of the terrible things about the pandemic was that I was staring at a telemedicine camera all day long, and I was like, woo, what on earth? Sorry, okay, so let's talk about taking the most effective disease-modifying therapy that you're comfortable taking and make sure that it's working. There are 28 different formulations of MS medicines. That's a lot, right? And the reality is some work better than others. And so they're not all equal. And the idea that you'll start on an easy breezy CoverGirl medicine, which is very safe and not very effective, and we'll see how things go, that's called the escalation model, is a bunch of hogwash, all right? That's been rapidly disproven as not a good way to up your game and live your best life. The reality is the earliest that you take the most effective DMT that you can get a hold of, the better you're going to do long term. And that's the reality of the situation. And I'm really excited that there's now research coming out which proves this point. And so I'm very, very excited about that. And I want you to know about that. So when we think about highly effective disease-modifying therapies, there's, out of those 28 medicines, there's only a couple that I really think rise to the surface as being some of the rock star medicines. One of those rock star medicines is an infusion in the vein given in a very weird way. It's called Lemtrada. All right, it's an induction therapy. It's hardcore chemo, kind of fallen out of favor because it's very, very difficult to give. I still love it very much. It's a highly effective medicine. There's another highly effective medicine that came out in 2004. It's an oldie but goodie. It's called natalizumab, Tysabri. Tysabri is an infusion in the vein given every 4 or 6 weeks, and that is a highly effective medicine. There's another class of medicines which I find to be highly effective, and in my mind, like Goldilocks, it's the super sweet spot, and that's the B-cell depleting medicines. Show of hands if you've heard about the B-cell depleting medicines. So B-cell depleters are the most utilized medicines to treat MS for a couple reasons. They're safe, they're highly effective, and they're not taken very often, which is kind of like lovely, all right? And so I want to spend a few minutes talking to you about these B-cell depleting medicines. There's a bunch. The OG of B-cell depleting medicines is a medicine called rituximab. It's not FDA approved for MS, all right? It is used in certain circumstances, but it's frankly kind of hard to get paid for. And rituximab is given through an IV, and it's given twice a year. Covering a medicine that's not covered by the FDA can be very, very challenging. And so at the Boster Center for MS, we don't give a lot of people rituximab. We can't get it paid for, and they, money doesn't grow on trees. There's another medicine, which I'm very fond of, called ocrelizumab. And I make up these words, by the way, ocrelizumab. That's not that. So Ocrevus is the short version of it. Ocrevus is a B-cell medicine, and it's the only medicine that's been FDA approved to treat both relapsing forms of MS and primary progressive MS, and that's a big deal to me. Right? Now, Ocrevus is given intravenously in the vein twice a year. And recently, they've come out with a newfangled way of giving it. They can actually infuse it under your skin. And so for my patients that don't have IV access, their veins are all jacked up, that's actually pretty fantastic because they have a way of taking that as well. So that's a B-cell depleter. There's another B-cell depleter called Briumvi, right? And Briumvi is another high efficacy medicine. It's another B-cell depleter, which is also given in the vein twice a year. Lastly, there's a B-cell depleter called Kesimpta, which is not an infusion. It's a shot that you give yourself, and it's given once a month. And I think it's kind of fantastic that we have several different B-cell depleting medicines which can treat MS, and they're all high efficacy medicines. Now you might say, well, what's your fave, Dr. Boster? Which one's better? And I have opinions, just like I like BP gas over Shell. But what I would say to you is talking about the differences of those medicines is kind of like arguing about a Ferrari and a Lamborghini. They're both really fast cars, all right? It's going to be really hard to get insurance for both those cars. And if you're having an argument about which B cell depleter, you're having a great argument because those are high efficacy medicines. I want to spend a few minutes as you start to get your food. Now you're going to eat and I'm going to watch and I'm going to smell. It looks really good. I want to talk to you a little bit about how B cell depleting medicines work. All right. Now I'm actually a graduate of Gahanna Lincoln High School, which is not far from here. So I'm a Gahanna Lincoln Lion. Woo-wee. And they have a newfangled high school. They just built a brand new high school, but I went to high school a few years back. And when I went to high school, it was massively overcrowded. They had a tiny little school. My graduating class had 117 people in it, and it was very hard to get through the hallway. I had this giant backpack, and getting through the hallway was a challenge. And every once in a while, two young men, when they were going through the hallway, they'd smack into each other. Now, in the 90s, when I went to high school, if two young men smacked into each other, there was only one way to settle that dispute. You met behind B building at 3:30 and beat the crap out of each other. All right, you had to defend your book bag honor. And I actually attended some of these social events. And so what I noticed was this. When two young men show up to defend their book bag honor, they show up with 6 of their very closest friends. Right? I noticed that every time I went to one of these social events that you'd have 2 pugilists that were going to punch each other in the face, and then you had 6 guys egging them on. Go ahead, man. I got you. I'll hold your book bag. I'll look for the teacher. If he kicks you, I'll kick him back. And these friends would kind of egg them on. Now, when you think about the way that MS attacks you, the T cell attacks your brain and spinal cord. All right? It's the sassy cell that's punching your brain and spinal cord. But here's the dealio. The T cell can't attack you unless the B cells get it adequately pissed off. Now, the immunologic term is co-stimulation, but I rather think about high school fights. And so what happens is the B cells stimulate the T cell to get all riled up to go in and sock you. What happens to a young man that defends his book bag honor at 3:30 and none of his friends show up? So he's going to get ready to fight, and he says, "Whoa, hold on. You know what? Never mind. He's not going to fight." And that's exactly what happens with B cell depleters. We simply kill all the friends. So you deplete all the B cells, so there's no more B cells, so the B cells can't stimulate the T cell to attack you. It's an indirect mechanism of action, and it's extremely effective, as it turns out, to treat MS. When I was in med school, I went to med school at the University of Cincinnati in Southern Ohio, and I was taught that MS only affected T cells. I also was taught that it only affected white women. I was also taught that it didn't affect gray matter. I was also taught that it didn't cause pain. I should get like a partial refund because none of those things are true. And the reality is B cells are very involved in treating MS, and non-white people and men have it. All right, but B cells are very involved in treating MS, and by depleting them, by suppressing them, we can really slow the disease down. And for all of those medicines I rattled off, there's excellent data supporting that these B cell depleters are some of the most effective drugs that we have available to treat MS. Now, I said I want you to take the most effective disease-modifying therapy that you're comfortable taking. And I meant the second half of the sentence. Because if a doctor ever tells you that something doesn't have a side effect, you just collect your stuff and you leave because they're lying, right? Because all things have side effects. And when we think about side effects, one of the consistent things I think we need to think about is kind of the risk-benefit, the balance of risk of infection. Now, B cell depleters, they don't massively immunosuppress you. This is not like John Travolta, Boy in the Bubble, but we do push down your antibodies a little bit. And I get a laboratory in my patients twice a year to make sure it doesn't go too low, right? And that way I can keep you safe. And my point here is we're trying constantly to balance, is the medicine the best medicine for you, and how do we do things to keep you safe? Now, remember I said I want you on the most effective DMT that you're comfortable taking, and I want to make sure that it's working. How do we make sure that it's working? We're going to take a disease-modifying therapy unless 5 things happen. Number 1, you have an attack on therapy. So if you're on birth control and you get pregnant, guess what? It didn't work, mom. All right, so if you're on a disease-modifying therapy and you have an attack or a new spot on your MRI, I'm not okay with that. That's the second one, is a new spot on your MRI just by taking it. Number 3, if you have accelerated rates of brain volume loss, I'm not very happy about that. Number 4, if it's not safe any longer, like in the example of B-cell depleters, if you're having lots of infections, that's not okay with me. Or if you can't tolerate it anymore. So if jabbing yourself is causing an ouchie yaya or something, then we're going to need to talk about a different drug. I want you to be 5-4 in your fight against MS. In the fifth one, we really have to work together. All right. Now, as I wrap up and start to open up the opportunity for questions, I want to talk to you about how you prep to live your best life despite having MS. All right, because it's a team sport and you're in charge of the team, right? You're the you expert. You know more about you than I do. You certainly know more about you than the MRI does. You know more about you than the MS Olympics when I have you do all the silly things. And so I need you to be large and in charge as we sort of drive the ship. All right, I'm a helper. You bring your expertise about your body to the table, and then I bring a bunch of stuff they made me read at University of Cincinnati to the table, and then we game out how we live our best life. So here's the homework assignment. Number 1, I want you to write down on a piece of paper, not right now. I want you to write down on a piece of paper life goals, 3 to 5 long-term life goals. Now, don't write down like, I want to be healthy, which is great, but I don't count that. I want to know things like, I want to start the first male harem in all of Ohio. I want to climb Monte Picchu, all right? I want to start a side hustle. I want to finish my master's degree. I want to walk my daughter down the aisle and she's 5 years old and she's not allowed to date until she's 40. Feel me? So I want you to list your life goals. And the reason's really simple. I know how to fight MS, and I can help you do that. I don't know why. You tell me why. You're the you expert. The second thing I want you to write down is rank order your worst symptoms. Remember that you're a you expert. So you have some cog fog when you get overtired. You have some fatigue, which can make it so it's real hard to do things. You got some bladder urgency where when you got to go right now. You have spasms in your leg. One of those is worse than the others, and you already know the answer. You know which one's worse because you're a you expert. So I want you to write them down in rank order. Number 1, number 2, number 3, number 4. I want you to write down questions that you have. So you're on the interwebs and you hear some shenanigans that MS is caused by parasites, which is not true, and you're not sure about it. So you write that stuff down. And then I want you to bring that piece of paper into your doctor's office and say, hey, Dr. So-and-so, I have some things I would like to share with you. And I have a couple questions. And you show them that you have a piece of paper and they're going to be ethically obligated to be like, okay. And then they're going to listen to the things you have to say. I'll give you a second tip, how you can communicate best with your doctor. Bring some backup. All right, bring a wingman. So I want you to bring a loved one, someone from your village. All right, bring a spouse or a best friend or somebody, because another set of ears can be really helpful. They can take notes for you so that you're not trying to write and talk at the same time. They can say, remember to ask them about the bladder and all those kind of things, and that can help you live your best life. Right? In quick summary, I think that we should have a shared goal of trying to make MS boring. I want you to live your best life despite having MS. And in order to do that, I ascribe for you being 5'4" in your fight against MS. Let's go through the 5 really quick, all right? Number 1, the very first thing is I want you to not smoke stuff. Number 2, I want you to exercise as part of your lifestyle. Number 3, I want you to eat smart. Number 4, I want you to practice daily mindfulness, 5 to 10 minutes, easy breezy cover girl. And number 5, I need to work with you so that you can be on the most effective DMT that you're comfortable taking and make sure that it's working. Now, as a bonus, before we turn things over to questions, I want to talk to you about something which is quickly coming down the pike as a brand new medicine, which will probably become FDA approved next year or a couple years. So it's a new class of medicine I'm very excited about called Bruton tyrosine kinase inhibitors. And they really need to work on their names because that ain't very catchy. All right, so they abbreviated BTK inhibitors. And the first time I told a loved one about BTK inhibitors, they said, ooh, bind, torture, kill? What? So apparently there's an American serial killer called the BTK killer, which has nothing to do with this drug whatsoever. I was forced to watch a very scary documentary that I wish I hadn't seen. BTK, Bruton tyrosine kinase inhibitor, this is a pill that you take. And what it does is really cool. Remember when I was talking about Gahanna Lincoln High School? And I was talking about how the B cell, if we kill the B cell, it can't attack, right? The problem with that is it can increase risk of infection. BTK inhibitors prevent B cell, T cell communication without murder. And that's pretty clever. BTK inhibitors also can get into the brain and turn off a cell that we can't reach called the microglia. And so we're very excited about studying BTK inhibitors. So at the Boster Center for MS, we're doing multiple clinical trials looking at BTK inhibitors. And I'm very, very proud that we can bring these trials to Columbus, Ohio, so that people in my hometown can participate in these trials. We're studying them in relapsing MS. We're studying them in primary progressive MS. We're studying them in secondary progressive MS. And there was a secondary progressive MS trial that we participated in. I'm very proud of that, called the Hercules trial. Hercules. And in the Hercules trial, we pitted a BTK inhibitor against a placebo for non-relapsing secondary progressive MS. And guess what? It worked. First time that we were able to slow down non-relapsing secondary progressive MS. Decreased it by 29%. That's a big deal. It's such a big deal that our FDA agreed to fast track that medicine. And so it's running through the FDA right now. We think it might get approval very, very soon. My name's Aaron Boster, and as always, thank you for learning about MS with me. I'm grateful for the opportunity. Thank you to Stuart and MS Views and News for giving me this chance. I'll turn the mic over and we'll answer your questions. Thank you very much.
A little behind here. Thank you. And thank you, Dr. Boster. Thanks for doing this excellent presentation. Who in the audience has a question? Don't all jump at one time. All right. I guarantee, okay, I'm going to be back there in the back of the room in a minute. I'm going to just start with a couple that are right here and then that were online because we've got a lot online, and then I'll get back there, all right? All right. First one online, somebody asks, if you have a patient with RA and MS, what would you recommend for that person to take?
So the question is, if you have not just one, but two autoimmune conditions, if you have rheumatoid arthritis and MS, what do? Now, the reality is if you have one autoimmune condition, you're more likely to develop a second autoimmune condition. That's true. And so I have plenty of patients at the Boster Center for MS that have MS and a second autoimmune condition like RA. So the first thing is you need two team members. You need an MS neurologist and a rheumatologist, right? And that's very, very helpful. The second thing is all the B-cell depleting medicines that I just talked about, they'll treat both. And so very commonly, I can use one high efficacy medicine and I can treat both conditions. And I do that in conjunction with the rheumatologist. It actually works out very, very well. And so it's not a hardship, but those are the two things that I like to do when I'm beating up on two autoimmune conditions.
That being said, what does the B-cell depleter do for a person with arthritis?
Say the last part again. B-cell depleter do for?
A person with arthritis.
So there's different kinds of arthritis, all right? But rheumatoid arthritis is a condition where you have antibodies you're not supposed to have, and they attack the joint, and they can destroy the joint. And so when you take a B-cell depleter, for a different way, you deplete those antibodies and you slow down the arthritis, the rheumatoid arthritis.
Okay, thank you. Next question is, have you heard of CNMAU8?
No.
Great. So I don't have to ask the second part of that question. Next, explain PIRA. No new lesions, yet my disability is progressing. No old lesions flare up and become active, causing worsening disability.
Show of hands if you've heard of PIRA. So some people have heard of PIRA. Do you know that there's two ways that someone with MS can develop disability? There are two ways that someone with MS can get worse. One way is that they have an MS attack and they don't fully recover. So an example of that would be, God forbid, you have an optic neuritis in your left eye and you can't see out of your left eye. And when your vision comes back, it only comes back part way, right? So now you're left with a residual deficit on your left eye. And we have a fancy term for that because neurologists are like super nerds. So we name stuff, we make stuff up. So we call that RAW, relapse associated worsening. Okay. And so one of the ways that you can get bad from MS is you can have relapse associated worsening. The second way that you can get bad from MS is another term that we made up called PIRA, progression independent from relapse activity. And this is where you're developing disability completely independent from an attack. And we think it has a lot to do with the old areas of damage wearing out. And I'm going to explain PIRA using a fictional violent example. All right, so here's a fictional violent example. Let's pretend that I had a bazooka, all right? And I used this mythical bazooka to blow a hole in that wall. All right, so I get carted off to prison and you're all like, I was there. I saw him lose his stuff and he blew a hole in the wall with a bazooka. And they don't fix the wall, All right. They just write a placard and say, this is where Dr. Boster lost his mind. And there's a plaque where there's a hole in the wall, and they don't fix it. Now, 20 years from now, when this nice establishment ages and the materials wear out, which wall falls first? The one with the hole in it, right? Because even though nothing's happened in the last 20 years, there's been structural damage earlier on, and so that wall falls first. When you have damage to your spinal cord and it recovers, it doesn't recover 100%, it recovers at 90%. And as you age, as your body gets older, that part wears out faster. And we think that's the underpinnings of PIRA, progression independent from relapse activity. And it's important to keep both those things in mind.
Thank you. Is PIRA the same as smoldering MS?
So we in the field of MS like to make stuff up. We love to name things, right? Smoldering MS is a marketing term. Now, it's a good marketing term. I like the term, but it's a marketing term, and it's intended to kind of encapsulate all the stuff that goes on in MS separate from new attacks and new enhancing spots. And it includes PIRA. And you're going to hear a lot more about smoldering MS as we move through the next several years of MS therapeutics, in part because medicines like BTK inhibitors probably help address smoldering MS maybe a little bit better than our current medicines, right? I would submit, and it's an unpopular view, that you're really just kind of playing with words and that you're dealing with the same concepts as PIRA. That's my opinion, which doesn't make me right. It just makes me opinionated.
Thank you. Whoa, very loud. So, got a question coming from the back of the room here, okay?
How do we know the proper height to adjust our mobility aids?
Excellent question. Very, very functional question. So how do we know at what height we should adjust our mobility aids? So can I grab, anybody have a cane? Is there a cane that I could, yeah.
Oh, no,
I'm not
you're
allowed to get off the
back
stage.
there.
Stuart says
You're
I get
not
in
allowed
trouble.
back there.
Somebody bring me a cane
I'm
and,
coming,
and I'll show you. This is actually very, very important. Let's give the gentleman a round of applause for having to run up here. Thank you. I wish he had the flame cane today, but all right. Okay. So the gentleman that let me borrow this cane is of normal height. I am not. All right. So this cane is way too high for me. So if you can see how my shoulder is jacked up over here and my elbow is jacked up, and this is not going to support me very well. In order to make the cane work, you want to drop your hand and you want the handle of the cane to hit your wrist. So you don't want to be walking like this. You want to walk with it down here. And that's how to adjust your cane height properly, right? Thank you. Can we give the gentleman back his cane?
How low is too low?
I think, well, I don't know that there's too low. I don't want you bent over like this. If you adjust the height of your cane handle to hit your wrist, you're in there like swimwear.
Great, thank you. Next one was handed to me. A question was handed to me. How many minutes per day do you need to be outside to get enough vitamin D?
It depends on how naked you are. All right, so the more naked you are, the less time you have to spend outside because it's a surface area thing. So when you absorb vitamin D, it's via a chemical reaction where the sun hits your skin. So if you're buck naked, it's a lot less time than if just your face is exposed. I have a built-in advantage over many of the ladies in the room because I can do it from the top of my head. They say that if you're wearing a halter top, so you have your arms exposed, maybe some of your chest exposed, and you go out in full sun, which we don't see in Columbus very often, in 15 minutes, you'll absorb 5,000 international units of D3, which is about the average that I like my patients to have.
All right, we got a question over here. I got to block the speaker.
Okay, so first I have an intermittent stutter, so I apologize. Before I ask my question, though, I actually would like to thank all the caretakers before I ask my question because you guys are amazing.
That's my job. That's my job.
Sorry. So, Dr. B, you often mention to your MS patients being 6 for 6, which the sixth one you would say would be advocating for yourself.
Yeah.
So I would submit to you that it is easier to advocate for yourself to your doctor as opposed to friends and family. So what do you say to those very well-intentioned yet overbearing friends and family when you don't want to hurt their feelings and you don't want to, break a connection, but you'd be like, I would like to do this myself. Please don't take it. Like, I don't know what to say.
So what she's saying is people oftentimes have the very best of intentions. And sometimes village members, in an attempt at showing love, say ignorant stuff. Not on purpose. They're not trying to be sassy pants, but like that can happen. Or they may try to help out in a way that's not helpful. All right. And that's very real. It's something that we deal with a lot. And so I think there's a couple different ways that we can address that. Now, I'm going to make a selfless plug. So instead of friends, I have a YouTube channel and I make these YouTube videos, and I actually have several YouTube videos on that topic. And so you can check them out if you wanted to go to my YouTube channel. Dun, dun, dun. You don't have to like and subscribe. But just to talk about it very, very briefly, one of the things that you can say is, thank you very much for caring about me. I've worked out how to do this with my doctor. All right. And so you say, I really appreciate, thank you very much for caring. But I got this. Right. And just tell them to stop. There's less polite ways, like saying like, oh, you don't look ignorant, but I'm not suggesting you do that with your friends and family. It has a lot to do with self-advocacy, right? And saying, I appreciate you caring about me. Believe it or not, that's actually not something that I can get into right now. And then just change the topic. All right. But if you want to hear like a 10-minute video about it, then check out my YouTube channel.
Next question.
So sometimes my mom will get like these sensory overload episodes where she will not be able to she'll collapse and not be able to move her limbs for several hours. And I was wondering if what exactly are these, and if there's a symptom of MS, and also if there is something to get rid of them.
So this is where I do that medical disclaimer thing where I said I can't treat you on the interwebs and I can't provide medical information or diagnose or treat you based on a single question, and you have to ask your doctor, which might be me. Yeah. All right. I can't answer that specific question, but thank you for asking it.
Any other questions out here? No? Okay. Can you tell us about CAR T-cell therapy?
Show of hands, have you ever heard of CAR T-cell therapy? A couple of you have. So CAR T-cell therapy stands for chimeric antigen receptor T-cell therapy. Show of hands, have you ever heard of a chimera? All right, so Greek mythology. The chimera was a mythical beast made up of different parts, like head of a lion, wings of an eagle, tail of a unicorn, I don't know. So it's like a composite animal. And CAR T-cell therapy is a really, really cool therapy, which has been successfully used to treat certain types of cancers. Now, what they do is they take a T cell out of a patient with cancer, and they manipulate it in a laboratory, and they teach the T cell to identify that person's specific cancer, and then they inject it back into that person, and their T cell now seeks out their cancer, binds to it, activates the immune system, and kills it. It's called chimeric because they engineer this antibody, or they engineer this T cell, so that it has the hots for your specific cancer. And CAR T cell therapy has been successful in curing some medically refractory B cell cancers that otherwise would have killed somebody. So that's a really big deal. Now, CAR T cell therapy is something which is now starting to be tested in autoimmune diseases, including MS. And there's actually a couple early trials where we're studying CAR T-cell therapy. A couple things about CAR T-cell therapy that we have to keep in mind. It is not prime time, and it's not going to be prime time for a little bit. When you design a genetically engineered T-cell specific to someone's cancer or MS, it treats one human. It wouldn't work in their twin. It wouldn't work in another patient. And it's super, super expensive, to the tune of like $500,000 per person. And so we have a lot of things to overcome with CAR T-cell therapy if it's going to be brought out to the masses. One of them is how to set it up and make it so that it doesn't just help one person. And obviously we got to get the cost down into like normal human levels. The other thing that we have to keep in mind is your immune system doesn't always like it when it's manipulated. And sometimes in the setting of CAR T-cell therapy, up to 30% of cancer patients that received this had a cytokine release problem, all right, where they had some very serious things. They had to receive the therapy in the hospital, and some of them had to receive like intensive care type treatments to keep them safe. So CAR T-cell therapy is personalized medicine. It's precision medicine. It's the opposite of old school chemo, where you just set off a bomb and burn the village to the ground. There's nothing left. Cancer's gone, so is all the other stuff. This is highly specific, and it just targets the problem, but it's not yet prime time. It's very exciting in near future.
Thank you. Next question. What can you say about tolebrutinib for SPMS?
So remember earlier we were talking about BTK inhibitors, remember that? So tolebrutinib is one of the many BTK inhibitors which are currently being studied to treat MS. And tolebrutinib is the drug that I mentioned earlier, I just didn't use its name, where we were studying it in people that have a non-relapsing progressive MS. So people that have relapses have a relapsing form of MS. And if you've had relapses in the past, but you haven't had them in a really long time, we call that secondary progressive MS. And if you're getting worse, having PIRA despite not having an attack, we call that non-relapsing secondary progressive MS. And we enrolled a bunch of patients into a clinical trial where they got either placebo or a BTK inhibitor called tolebrutinib. And we enrolled that trial at the Boster Center for MS here in Columbus. And what we found was, compared to receiving dummy drug, we were able to slow non-relapsing secondary progressive MS by 29%, which is highly statistically significant and very, very exciting. It's the first time in the history of the universe that we were able to do that. That's the drug I was mentioning that is being fast-tracked at the American FDA, just like the vaccines during COVID were fast-tracked to get them done quick. And we think it's going to see the light of day. We're very, very excited about that. There's another trial that we're participating in at the Boster Center for MS called the Perseus trial. And in the Perseus trial, we're studying tolebrutinib against placebo in primary progressive MS. And we're very, very hopeful that this will be a successful tool to treat primary progressive MS.
Awesome. Thank you. All right. I've got a lot of questions online, but if any of you in the audience have a question, please raise your hand and force me to get up and exercise to get over to see you. Okay. I really need some exercise. All right. Too much plain food. All right. So make it happen, please. All right. So the person that was asking about that CNMAU8 earlier is now saying that your friend Gretchen posted something on a video today about this. And so that's why they were asking, but it's not part of a clinical trial or anything, but just letting you know about it, because now you'll ask Gretchen about it, Dr. Gretchen about it. All right. All right. Next, person asks, how can I make my pelvic floor stronger?
Ooh-wee. So many people with MS have invisible symptoms. All right. So for example, some people with MS, they have problems with the up theres. You know, the up theres, energy, mood, thinking, and memory, the up theres, that kind of stuff. And some people with MS, they have invisible symptoms in the down theres. You know, the down theres, bowel, bladder, bedroom. And if you would like to make an adult human miserable, mess with the down theres. All right. Have someone who has a urinary urgency. And when they got to go, they got like 10 seconds before they're going to start to go. Or they can't empty their bladder. Have someone that can't poop but once every 2 weeks. Or can't control it when they need to poop. Have someone that has pain during intercourse. Or can't feel anything down there. Or can't achieve orgasm. Right? This is unfortunately all too common in the setting of multiple sclerosis. One of the secret weapons to improve the down theres is a pelvic floor physical therapist. So there's lots of different physical therapists. Like if you bust your knee, they'll send you to like the nicest, smiley sadist you've ever met, and they'll make you do all kinds of horrible, terrible things in a gym, and they'll get you back moving around. That's a physical therapist. We love them. Yeah. And there's neurophysical therapists. They go to school extra long. They go for an extra couple years. So Dr. Gretchen Howley, who's just referenced, she's a neurophysical therapist. And neurophysical therapists, they do extra schooling to understand things like unsteadiness of gait and blindness and spasticity and weakness and things that people with MS may experience. And there's another type of physical therapist called a pelvic floor physical therapist. Now, when I first met my favorite pelvic floor physical therapist, Corrine, she would say, now, Dr. B, you got to tell them I get up in their business. And what she means is she puts you in stirrups and she gets up in your business. and she teaches you how to reactivate your pelvic floor, something fierce. And I have seen pelvic floor PT help rehabilitate the down theres and have better control of bowel, bladder, and sexual function. And so if you have difficulties with the down theres, don't just accept that. Get ye to your neurologist and say, hey, I want to talk with a pelvic floor physical therapist, and I hope she gets up in my business and can help me have a better control of bowel, bladder, and sexual function.
Microphone's needed, right? All right, next, is tinnitus a symptom of multiple sclerosis?
So in the Midwest, we call it tinnitus, but tinnitus also works. And it simply means that there's ringing in your ears, right? And lots of things can cause ringing in your ears. MS is one of them. And so we can have ringing in your ears, tinnitus or tinnitus from MS. It can also happen from a host of other things. It's very, very annoying and frustrating and hard to treat. And it's particularly problematic when there's no extra sound, like when your kids and the dog and the husband all shut up and it's finally time to go night-night and you're laying in bed and it rings really, really loud. It's very, very annoying, the tinnitus. And that's because there's no auditory input coming in your ear. And so as that nerve fires inappropriately, it makes your brain think it's hearing a sound. So what you do is you get out your smartphone and you put it on white noise, or you turn a really loud fan on and you provide your ear with something else to hear, and it can dampen that tinnitus or tinnitus.
Thank you. Next, at 67, my neuro wants me on Ocrevus for 1 year only. I had new lesions on my last MRI. Does this make any sense?
So someone has recently celebrated a birthday, all right? So now they're a very young 67 years old, and they have new disease activity, which brings up a really good point. MS doesn't stop just because you happen to celebrate a particular birthday. You'll die with MS, not from it, but with it. And there's an issue that I have with a lot of American neurologists. They have this horrible problem called ageism, where they decide just because you celebrated a certain birthday that they're going to stop your medicine, which is enraging to me. And here's an example of someone who at 67 years young is having new disease activity. So I like part of what the neurologist said. Let's put them on a highly effective disease-modifying therapy. One of the B-cell depleters that I talked about today, ocrelizumab, Ocrevus. That's a highly effective disease-modifying therapy. And it's really, really good at stopping new spots on your brain. So I think that's awesome sauce. Now, the neurologist apparently said, let's do it for a year. And what I hear is, let's do it at least a year. All right, so you could do it for at least a year, and then you might choose to do it for like 20 more years. And I'm not sure why they said at least a year or why they said a year. Maybe they're trying to balance that risk benefit. But I like the idea that we're going to start a high efficacy medicine to shut down new MRI brain activity or new MS disease activity. And then I would submit to you that at the end of the year, maybe we're doing great because the medicine's working, and we might choose to keep on keeping on.
Thank you. A follow-up to that is your favorite question. What's too late in life to begin a therapy?
So I'm oftentimes asked, when do you stop a disease-modifying therapy? And I have a very, very strong opinion about this. So I've been treating MS for nearly 2 decades, and I have never once treated when somebody died. Never. I refuse to do it. I have drawn a line in the sand in my therapeutic practice that when you die, I refuse to continue to treat you. Now, there's lots of reasons for that. All right, number one, we've never studied MS disease-modifying therapies in dead people. All right, number two, a lot of the medicines work by your body circulating the medicine. So if you take Briumvi in the arm or Ocrevus or give yourself a Kesimpta shot or what have you, it's got to circulate through your bloodstream. And if your heart's not pumping, it just doesn't work. Also, frankly, it's very hard to get these medicines paid for after death. So I don't do that. Now, pre-death, I have a very simple rubric. If you have neurological features that you're fond of, things like seeing or smelling or moving your hand or having an orgasm or hearing something, those are all neurological things. I want to preserve the neurologic reserve. And so I want to stop medicines at death, but not beforehand. Now, that doesn't make me right, but I am. I mean, it doesn't make me right, excuse me, it just makes me really opinionated.
Next question from a gentleman who would like to know what can be done for a person with the down theres not getting enough sensory
Stimulation.
whatever. Yes.
All right, so the question is, and this is true for boys and girls. Sometimes MS can make your leg like numb, where you can't feel it very well, or make your hand numb and you can't feel it very well. Sometimes MS can make the down there's numb and you can't feel very well. And so your partner may be working their tail off, literally, and you can't feel what's happening, which is terrible, right? So let me share two things that we can do about that. Two things that we can do about that. One thing is you can get a water-based lubricant, which increases skin sensitivity, right? And so you can slather it on down there because that optimizes skin sensitivity. Number two, you can buy a plug-in-the-wall vibrator. I own two, all right? So I like the Hitachi Magic Wand. Now, I don't get paid by Hitachi, but I would if they wanted to sponsor me. And the Hitachi Magic Wand is a Japanese back scratcher, right? So it looks like this, but it's much bigger, and it's got a big white part up here, and you plug it in the wall, and it goes like that. And the Hitachi Magic Wand provides what I call overdrive stimulation. Let me break it down for you. Right now, despite the microphone, I'm using my indoor voice. I'm not screaming, right? Because there's not a lot of interference between the speaker and your ear, so you can hear me. If everyone in this room started talking really loudly, I would have to raise my voice and basically start screaming so that you could hear me, all right? Because there would be interference between the speaker and your ear. I would have to provide overdrive stimulation so that you could hear what I was trying to say. When you have problems with the down there's and there's numbness and you can't feel it, sometimes that's because the stimulation, as the information goes up the spinal cord, it dies. So the brain never learns what you're trying to do. So if you use a water-based lubricant and a plug-in-the-wall vibrator, you can provide overdrive stimulation, and the brain can be like, okay. And oftentimes when both boys and girls take this advice, they'll come back with thumbs up and say that was adequate for a fantastic Friday or Thursday or Wednesday morning or whenever they have a chance to use it out. And so that's one thing that I think that you can try. A second thing that you can try is improved communication with your partner. Now, many partners, when they have an opportunity to be intimate, they've done it the exact same way for years without talking about it, right? I mean, think about it for a second. You kind of just fall into a routine, and you don't necessarily discuss what you're doing. My turn, your turn, lay like this, watch TV, right? There's like a pattern to what you do. And that's fine and good, but what may be happening is a lack of communication. Your partner might not know that you can't feel that. They might not know that because you haven't told them. So with clothes on, I want you to have a frank conversation. Hey, can we talk about some things? And I want you to share with them things that work and don't work in the bedroom. I want you to share with them things that are uncomfortable or hard for you to do and things that you might want to try out. And I have found time and time again, if you have this conversation, it makes the experience much more successful. All right. I'm not judging success by a eureka moment. I'm judging success by having a really great time in intimate time with your partner. And that can include talking about expectations. That goal that we had when we were 20, that's really hard for me to do right now. But I still want to be close and intimate with you. All right. And so those are two things that I have found work very, very well if you don't feel very well in the down there's.
This person's gotten quite intimate. So he's saying that his girlfriend doesn't want him to touch her ever again until he can have an orgasm.
There's a lot of fish in the sea.
Right.
I guess all I would say is that's a great opportunity to start a conversation about goals.
Right. Okay. Next question. How do I stop feeling pain?
So remember when my professor at University of Cincinnati said that MS doesn't cause pain? And my professor was really wrong. MS causes lots of different kinds of pain. Let's talk about just 3 quick things we can do to decrease pain in MS. One of them is physical therapy. The stiller you are, the more neuropathic pain will hurt. That's a fact. And so working with a neurophysical therapist to get your movement on is actually a great pain control mechanism. It's one of the least appreciated pain control mechanisms. Something that doesn't work, by the way, is narcotics. Narcotics don't work very well to treat neuropathic pain, so I don't use them in my practice. But there are neuropathic pain medicines which can be very effective. Now, most of these were invented for other purposes, like medicines that were invented to treat seizures or invented to treat forms of depression have a secondary benefit of treating pain. And so they stabilize cell membranes and they can decrease neuropathic pain quite significantly. And so that's a way to do it. Another way to do it, as weird as it sounds, decrease pain, is to get more sleep. Fatigue ramps up neuropathic pain something fierce. And you may find when you get a bad night's sleep the next night, you hurt a lot more. And so getting restorative sleep are 3 of many, many ways to control neuropathic pain.
Thank you. Next, can Dr. Boster explain his thoughts on Mavenclad versus B-cell depleters?
So Mavenclad is, in my opinion, king of the pills. All right, it's one of the MS medicines. It's one that I'm very fond of. And it's a very weird drug. It's arguably like the weirdest of all the drugs, in my opinion. All right, Mavenclad is a pill that you take on Monday, Tuesday, Wednesday, Thursday, and Friday. And then you're done for the month, which is really weird. It's like a reverse birth control pill, right? And so 5 pills the first month. The second month, you repeat Monday, Tuesday, Wednesday, Thursday, Friday. So you take 10 pills. Then you're done for the whole first year. That's 10 pills the first year, which is like really weird. And then on the anniversary, you repeat that process once. 5 pills the first month, 5 pills the second month, and then you don't take it again ever unless you have new disease activity, which is really, really weird. So Mavenclad is a discontinuous medicine. The B-cell depleters, these highly effective medicines that I mentioned earlier, are continuous medicines. You take them continually. You take the Kesimpta shot every single month. You take the Briumvi twice a year on a continuous basis. Mavenclad's doing something a bit different mechanistically because it's not trying to deplete a B cell, it's trying to reboot a B cell. And once you reboot the cell, then it behaves differently. And I'm going to give you an example, okay? So your immune system is not a dog. Don't say that Dr. Boster said that, but I'm going to use an example of my dog, okay? So when my dog was a puppy, she thought it was awesome to get on the couch, and I didn't want her on the couch. So I would yank her off the couch, no, and I'd pull her off the couch. And every time she got on the couch, no, and I'd pull her off the couch. And she learned really quickly that getting on the couch was not a good idea. Once she learned that, I didn't need to remind her anymore. Now, I didn't shoot the dog or build a fence around my couch or throw my couch out. I just taught her not to get on the couch, right? And then I had a durable benefit in the absence of retraining my dog. Mavenclad, as a discontinuous therapy, is trying to reboot the immune system. And once you get it rebooted, you don't have to keep reminding it, which is how you can have a durable effect in the absence of retreatment. And so it's a very, very weird drug. That's how it's different.
Thank you. Next, which side would you use the cane on? If your left side is more stiff than the right side, what do you do?
So it really depends on the kind of problems you're having. So you can use a cane for a whole bunch of different reasons, okay? And so it really depends on which problem you have. So I can't say it's always on the opposite side or it's always on the same side. That's where the neurophysical therapist can really up your game and help you a whole bunch by helping you figure that out. Now, just to give you, I don't want to give examples because each example would change the direction of the cane. But that's one that you can field with the neurophysical therapist quite easily.
Okay, next. B-cell therapies kill all your protective B cells. With that, you're without protective B cells for 4 to 5 months until they reactivate.
False. Yeah, that's false.
Specifically, Mavenclad supposedly only kills MS B cells coded with SD20 or CD20.
Also false.
And leaves all other B cells intact. Please confirm this benefit.
Yeah, so everything that was just said is actually inaccurate, fortunately. Because if it was accurate, then that would be really, really scary. So the immune system is actually way more complex than I was sharing. All right, and just to talk about it for a quick second, when you look at the breadth of the immune system, it's really, really, really big. And there's 2 halves to the immune system. So there's the innate immune system, which is actually the bigger part, and there's the adaptive immune system. And when you take a B-cell depleter, you don't touch the innate immune system. Now, the adaptive immune system is also really big, and it has 2 parts also. It's got the cellular, the T-cell compartment, and then it's got the humoral B-cell compartment, okay? And these B-cell depleters don't touch the T-cell compartment at all. Now, there's not just one kind of B-cell. There's a bunch of different kinds of B-cells. And B-cells grow up. So when they're born, they're stem cells. They have no idea. They're like college freshmen. They have no idea what they want to do when they grow up. They ain't sure yet. And then they go from a stem cell to a pre-B cell, where they're like a teenager, still trying to figure it out. And then they can become an adult B cell, and that adult B cell can become a memory cell or a plasma cell. Okay. Now, the B cell depleters do not affect the stem cells, and they don't really affect much of the plasma cells, just in the middle. And so you're not removing all of the protective B cells. You're removing a sliver of a part of the immune response. And so fortunately, that's a bit inaccurate. And I'm not pointing fingers. The immune system is super weird and complex. But the reason that's so important is we want to use the most effective disease-modifying therapy that you're comfortable taking, and that includes minimizing risk of things like infection. And so I'm really glad that that's the case.
Thank you. Before I get on to the next question, is anybody going to help me exercise? Oh my gosh, they're going to let me get fatter. I got it. All right. Hi, my brother was diagnosed with MS in 2019. His diagnosis was relapse remitting, and in 2023 was changed to SPMS. He's on rituximab since 2023, but yesterday his MRI shows active lesions and his walking has deteriorated. Now he is recommended to take a steroid. What other options are there when rituximab is not working anymore?
Not enough information to answer that question. What I'll share with you is there's a bunch of options, a bunch of options. I unfortunately don't have enough information to comment with just those 4 lines. So that's an excellent question to ask your MS provider, for sure.
Thank you. Next, let's find a good one here. Is brain, they're all good, but some are longer than others, and I want to get past the long ones. All right. Is brain volume loss difficult to measure?
No, not so much. So everyone after the age of 18, their brains shrink a little bit each year on purpose. Just like we all get a little bit shorter as we age, some of us more shorter than others. And just like our skin gets thinner as we age, the brain gets a little bit smaller each year as we age. So after the age of 18, it starts to shrink a little bit. And I would say early on, it's going to shrink about 0.02% a year, a very small amount. In the setting of untreated or undertreated MS, the brain can shrink upwards of 10 times faster than the healthy population. And brain shrinkage, which is called atrophy, because God forbid we just said shrinkage, that would be too easy. So we have to come up with highfalutin words. So brain atrophy or brain shrinkage correlates with bad things. Like increased brain shrinkage leads to increased not thinking clearly and increased likelihood of progression of disability. So brain shrinkage is bad. Some of the most effective, the highly effective medicines like the B cell depleters we talked about today, they can slow brain volume loss. They can slow down the brain shrinkage, which is really, really fantastic. Very, very helpful. And the question is, can we measure that? So one of the ways that we measure that, and this is done on the MRI, all right? So one of the ways is literally old school. There's, when I'm looking through the MRI, there's a part in the center called the third ventricle. And when I was in training, I was taught to get out a ruler, like an actual ruler, and measure the width of the third ventricle. And I can compare one year to the next and see if it's getting wider and how fast. And that's like a poor man's way of measuring brain volume loss. A much better way of doing it is there's fancy pants software, which is essentially artificial intelligence before AI was cool. And there's a software that I use at the Boster Center for MS on all of our scans. And it's a software which measures the volume of the brain like a sphere, and it compares the size of your brain and the parts of your brain to someone your age who doesn't have any neurological problems. So it'll tell me, compared to someone your age, that part of your brain is what percentage? It's the 99th percentile, you got a big brain. It's 10th percentile, you have a small brain. And you can see how it changes over time with serial plots. And so that's information that I use as I try to help people with MS live their best life. It's information that I use to help assess whether I think a disease-modifying therapy is doing its very best job. And so, yes, you can measure that.
Thank you. The next one is a very non-selfish question.
I like the prelude. Okay.
How do I leave my brain to science?
That's a great question.
Thank you. Non-selfish.
Yeah, that's fair. So some people are satisfied having their disease treated, which is fantastic, right? Some people, they want to do more than that, and they want to stick it to the disease. And one of the ways that you can stick it to the disease is you can participate in MS research. So I'm very honored that many people at the Boster Center for MS will volunteer for clinical trials where they'll donate their body to help figure out if drug A is better than drug B, or if a particular device might teach them more than a different device. That's a way of fighting back. Another way to fight back is to literally donate the holiest of holies, the supercomputer that runs the body, the brain, to science. And what that allows friends of mine like Dr. David Pitt, who is a neuropathologist at Yale, is to slice up the brain and study it chemically and help test new therapies and develop new theories and find answers for things that we could not find otherwise. And I want to tell you a really funny, quick story, because neuropathologists are weird men and women. And so Dr. Pitt and I were professors together at the Ohio State University, and we were not asked to play football. And at Dr. Pitt's lab, he had like 30 brains in jars, like Frankenstein. All right. And when he got a job at Yale, he put all the brains in his trunk and in his back seat. And I reminded him that that might be a federal offense. And he said, oh, they're not going to stop me. And the poor guy drove by himself with 30 brains in his car from Ohio to Connecticut and never got stopped. and please don't tell the police. Yeah. So what that means is that 30 people saw fit to give him a gift that nobody else on earth could give him so that he could study MS and find cures and better therapies. So how do you do that? Well, here's the deal. You have to set it up long before you die. Because if you want to donate your brain upon death, we have about 4 hours, maybe 6 hours, and the brain starts to rot. And so we have to act very, very quickly. So here's what you need to do. Number one, you need to find an academic center near you that has a brain donation program. Number two, you need to have a meeting with your family, because every single survivor in your family has to all understand that you want your brain donated, because if they stutter and stall, or they don't know, or they're searching for the paperwork, it'll be too late and it won't work. And so you have to get those two things in line. And the brain donation program will teach you the steps that you need. And I'm being serious. You really have to talk to your kids and your spouse and be like, I'm not joking. Upon death, call this number, because you're not going to be able to make that phone call.
Good answer to a non-selfish person. Okay, next. What are your thoughts on MS and parasites?
Bullshit. I'm sorry. Sorry, I had something in my throat. I apologize to you. So MS is not caused by parasites.
What is your idea on gut bacteria?
So we have a bunch of pathogens that live in our bellies. We have a bunch of microbes, that live in our bellies, particularly in the colon. So it's hypothesized that you have about as many microbes in your body as you do human cells. And most of them are in your gut, right? And they populate your gut. They're supposed to be there. They're your friends. They're called the microbiome. And those gut bacteria help you do things that are really, really important, like metabolize and process your food, right? And so the microbiome is actually very, very important. And recently, over the past 10 years, we started to understand that changes in the gut microbiome have an impact in human health, like can relate to depression, can relate to some autoimmune conditions. And there's actually a gut-brain connection, believe it or not. Now, people with MS, for reasons that we're not clear about, have something called dysbiosis. That's a Scrabble word. Dysbiosis means you got jacked up gut bacteria. You got the wrong kind of gut bacteria. And we don't know why, but it's true. And so there's research going on trying to figure out how to correct the microbiome, how to correct the gut bacteria. And that's really early research, but it's kind of exciting to think that we might be able to change the different flora that live in your gut, the microbiome, to help slow down an autoimmune condition like MS. It's not prime time yet. It's being studied. So one of the studies, and I'm glad that you're all finished eating, which is being looked at is called a fecal transplant, which sounds exactly like what it is. All right. And you take someone else's healthy gut bacteria and put it in a pill and you swallow it. and it goes into your gut and it populates your gut bacteria. And so that's being studied right now. So when you talk about being heroic and participating in a clinical trial, that is like some real deal Holyfield heroism as people are helping try to figure out whether they can correct the microbiome. Now, a couple other ways to try to adjust the microbiome without a fecal transplant is to take something called probiotics. So show of hands if you ever heard of probiotics. Yeah, a lot of you have. So probiotics is a capsule, all right? And inside the capsule are billions, with a B, billions of healthy gut bacteria that have just been stuck in the capsule. So when you swallow it, it goes in your gut and it kind of spreads out and it helps replace the gut bacteria. Now, you don't have to buy it in a capsule. You can eat any fermented food is high in probiotics, like kimchi or sauerkraut or like pickles, like these fermented foods. They can provide you with gut bacteria that can do that. And so a lot of my patients with MS have constipation, like real bad. And they can make it better by taking a probiotic and adjusting the gut microbiome. Another thing you can do to adjust the gut microbiome is you can feed the microbiome fiber. See, the gut bacteria, they don't eat steak, they eat fiber. Like fiber is an indigestible solid. And so when you give your microbiome fiber, it helps feed them and make them healthier. And they break that down into something called short chain fatty acids. Some of those short chain fatty acids stimulate your immune system in really beneficial ways. And so you can get fiber from lots of different fruits like pears and plums and apples and peaches and stuff like that. Anything green like broccoli is really high in fiber. Avocados are high in fiber, and things like berries are very high in fiber. But there's an entire aisle in Kroger's called I Can't Poop. And in that I Can't Poop aisle, you'll find fiber capsules like FiberCom or Memory-Cognition. And so you can just add that into the groove. So those are things you can do to adjust the gut microbiome.
Thank you. Next one, person wants to know if having spinal stenosis surgery, how would it affect his MS?
So sometimes nature is too generous. My mentor used to say that all the time. Sometimes nature's too generous and you can have more than one thing going on. So you can have an autoimmune disease that affects the spinal cord, multiple sclerosis. And you can also have a disc that slipped when you were playing football or picking up your grandson and it's pushing on the spinal cord, all right? Or you can have the bones that surround the spinal cord get tight. Stenosis is a doctor word for narrow, right? Spinal stenosis is where you're smushing the spinal cord. And the problem is that, well, number one, that's not uncommon. It's actually very common. And number two, it can cause neurological problems because if you smush the spinal cord, you can have numb and tingly and weak and the Daltheirs don't work, all the things that you may see in the setting of MS. So when I, as an MS neurologist, see spinal stenosis, I send you to the friendly neighborhood neurosurgeon to have the disc plucked out and have it fixed. Why? Because it's a fixable problem, right? I can't cure the MS, but if I don't fix the fixable problem and you get worse in your arm, I don't know which one's causing the problem. So I like to remove that variable so that we're good in the hood. Very, very important.
Thank you. For patients who have been prescribed painkillers such as OxyContin or oxycodone, how do they get off of this and what kind of medicine could they go on that could be just as effective?
So as I mentioned earlier, narcotics don't work to treat most forms of MS pain, right? If you cut your leg off, God forbid, narcotics are awesome, all right, for acute pain. If you have a heart attack, God forbid, narcotics are awesome, all right, for acute pain. But chronic pain, and a lot of the MS pain that we see is chronic forms of pain, narcotics don't work very well. And they could also cause some problems. And so we spend a lot of time trying to help people come off narcotics. And it can be very, very challenging, right? There's an epidemic of narcotic use in the United States and mostly the fault of doctors for administering them. So I don't use narcotics in my practice. But what I do is I help people get off narcotics. So without going into a long story, one of the best ways to help decrease the getting off narcotics is to reduce them very, 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 very slowly. So I may help someone get off narcotics over a period of like 6 months, like a really long time. And we want to use other medicines to help the discomfort. And we'll do a full court press. We'll do therapy, like talk therapy to help with pain. We can do meditation to help with pain. We can do physical therapy to help with pain. We can do neuropathic pain medicines to help. There's a host of things. We can do medicine by Edison with spinal cord stimulators. There's a bunch of things that we can do to try to control the pain while we slowly get them off the narcotics.
Thank you. Anybody out here yet? I didn't think so. Next.
We have some people in the very back.
Really? Wow.
Yep.
I'll be back there in a minute. I'm going to actually run to you just to make up for it. Break my ankles on the way, though. What pharmaceutical company is supporting studying in the fecal transplant trials?
None that I know of.
Okay, well-
I'm not aware of a pharma company that has picked up that gauntlet, so to speak.
All right. Next, so I can have time to run back there. TOA patches. Can you tell us about them and do they work?
I'm sorry.
TOA.
I need like a water. Yeah, so I think tau patches are a bunch of BS, and I would not recommend using them. And I think the science behind them is bunk. So I would rather you spend that money to buy like chocolate cake, which is delicious. Right, it is. Chocolate cake is delicious.
I get the mic.
Oh, that's right.
What are the side effects of Ocrevus, and is one more common than the other?
So I would submit that one of the side effects of Ocrevus, or any of the infused B-cell medicines, rituximab, Briumvi, these are all infused B-cell medicines, is a risk of an infusion reaction. Now, with the first Ocrevus infusion, you got about a 1 in 3 chance of having a mild reaction. And we actually give you lotions and potions to make that better tolerated. So we give you a little bit of steroid, a little Benadryl, a little hug, a little acetaminophen, and we can get you through that. And then the risk, because your body tolerizes to it, goes down below 8%. And that's true with the other B-cell depleting medicines. The numbers are different, but it's the same concept. And so I would submit to you that we're able to get people through infusion reactions very well. So at the Boster Center, we give a lot of B-cell depletion medicines, and my nurses are freaking rock stars at giving it. They're very, very good at identifying the problems and then treating it, so we can get you through that. Another risk of all the B-cell medicines, because it dampens a sliver of your immune response, is you can increase the risk of infection. And the way that we mitigate that risk is a couple things. Number one, this is real highfalutin. We ask you if you've been having lots of infections. And if you say yes, then we have to pay attention to that, all right? Number two, I want you to get your vaccinations, all right? Because if you're vaccinated, that can prevent a lot of infections from occurring. Number three, we check laboratories. So twice a year on my B-cell treated patients, I check a couple laboratories to look at their antibody levels and their levels of their lymphocytes to make sure they don't go too low. And through that, we can really mitigate that risk. One thing that they don't do is cause cancer. And there was a lot of questions about whether B-cell depleting medicines could cause, say, breast cancer. And the short and the long of it is they don't, which is fantastic because most people with MS have breasts. And so if they did, that would make that like not a very good medicine.
Next question.
How would you address like dietary restrictions in the form of MS other than the single ingredient thing that you talked about before and not eating a lot of preservatives and other?
Yeah, so what else can you do to live your best life? Remember, because I want you to be 5'4" and your fight against MS. That was not your best performance. Now, Matt, you got to wake up back there, buddy. All right, so I want you to be 5'4" and you're fighting. That's so much better. Thank you very much. And one of the things that I want you to do when you're 5'4" and your fight against MS is to eat smart, right? And so the gentleman said, well, what all can you do? So you can up your water game. You can supplement vitamin D. You can avoid ultra-processed foods, fried foods, fatty foods, foods with high fructose corn syrup, diet foods, foods that have ingredients that you can't pronounce. Those are all things that you can do. All right, you can increase your fiber intake. So I like people to have about 28 grams of fiber a day. You can increase your protein intake. I'm looking for about 1 gram of protein for 2.2 pounds of body fat. You can decrease your overall carbohydrate intake. All right, those are all things that you can do. And you mentioned, thank you very much, sir. You can mention, as you did, single ingredient foods. Those are whole foods, things like broccoli, right? Apple, chicken, right? So those are really great ways of trying to improve your diet. Now, if you start to read about this stuff, you start to get into fighting matches between different MS diets. And some of them say, whatever you do, never, ever, ever eat meat. And some of them are like, well, eat some meat. And some of them are like, well, whatever you do, don't have milk. And some are like, well, milk's okay. And the common thread through all of the diets is food quality. So one of the tricks is when you go to the supermarket, don't shop in the center of the supermarket. Shop on the edge of the supermarket. Food should rot. So if you have food that doesn't need to be kept in a refrigerator, then it's probably processed or ultra processed. And food should rot. If you want to do an experiment, and this has been done in academic centers many times, go to like a McDonald's and buy a cheeseburger, and then don't eat it. Just leave it on your desk. And in 10 years, it'll look exactly the same. No, I'm being serious. It'll look just like a cheeseburger. It'll have the cheese, and it'll have the meat, and it'll have the pickle, and it'll have the bun, and it won't look exactly the same. If you buy the real deal Holyfield, if you buy like some bread, some real bread, it'll last like a day and a half. You got to eat it right away, right? Because it'll go bad. It'll grow mold. All right. If you buy like beef and you leave it out, you can tell because it'll smell. And so you should buy food rots. If you're eating really healthy, you're going to the supermarket more than once a week, for real. You're probably going to the supermarket twice a week, at least. So those are some ideas.
Thank you. Before I get on with these questions, the server has a question for you. Would you like a meal?
No, I'm solid. This is delicious. Thank you.
There you go. Perfect. Thanks. Next. God, so many questions. What is your thoughts on the GLP-1s and MS? And do you think that people with MS should be exercising while using a GLP-1?
So this will be the second to last question. So GLP-1s, these semaglutide medicines, are injections that you can take that were invented and are used ubiquitously to help with diabetes. And they're amazing medicines to help with diabetes. And they help people lose weight, right? And they work in two ways. They slow gut motility. So gut, you don't have food go through you as fast, so you're full because it ain't gone yet. And they change your brain chemistry with neurotransmitters so that you're satiated faster, you're not hungry. And they can help people lose a lot of weight. And lots of people have figured out ways of getting a hold of GLP-1s. One of the issues that I have with GLP-1s is not that they don't work. They work great. And it looks like they're safe in MS, by the way. It's that when you stop them, you haven't changed any behaviors, and so you put the weight back on with a quickness. And so one of the things that I think is imperative if you're going to use and benefit from a GLP-1 is that you also work on changing behaviors. So like food choice and active lifestyle need to be ingrained into that so that when you stop the GLP-1, you don't just put all that weight back on. Now, I did share that early research looks like GLP-1s are safe in the setting of MS. And from a physics standpoint, if you're carrying extra weight on a weak leg, that's harder on you. And if you lose weight on a weak leg, that's easier on you. And so there is some significant value in shedding pounds as it relates to motoric moving and doing things with your body. So it can be very helpful to lose weight. And that's one of the ways that we can do it.
Great. So guess what? I just whittled down this whole list of 20 questions down to one.
Bingo.
There you go.
All right, let's do it up.
I'm trying to be complacent to you, all right? All right. So we're going to make this one interesting, all right? NFL, also known as neurofilament light change, nothing to do with your local football team, and Octave. Okay, can you tell us about both of these tests and what the differences are?
Absolutely, that's a great one to end on. So raise your hand if you ever heard of a biomarker. Some of you have heard of biomarkers. So a biomarker is a tool to help you understand a person, right? So if I give you a math test, your score on the math test is a biomarker for how well you understand mathematics. It's not your understanding of math, it's just a biomarker for, like, if you get an A, then you probably understand those math concepts really well. And in medicine, biomarkers are awesome because they help us learn about you even in your absence. So for example, we were talking about diabetes. There's a blood test that you can draw to tell us how well your sugar is under control for the last 3 months. That's called the hemoglobin A1C. And so I can get a hemoglobin A1C lab and I can look at it and I can have a really strong sense of how well we're controlling your sugars, which that's a biomarker. There's a ubiquitous biomarker, a biomarker that we use a lot in MS. What is it? The MRI machine. The MRI takes a picture of the structure of the holiest of holies, the supercomputer that runs the body, the brain. It takes a picture of the superhighway, the spinal cord. And that structural imaging is a biomarker for how you're doing. If we see new white spots in the holiest of holies, the supercomputer, we know that your disease is not under the best control because you have new brain damage. Even if you haven't manifested new problems, that's a biomarker. Now, the MRI of the brain shows a picture of structure, which doesn't teach you all the things. So if I take a picture of your house, I don't know whether you're having dinner. I don't know whether you're watching television. All I know is like the roof is intact and you got 2 windows and the door's closed and some of the shingles are falling off. Like I can just tell you about the structure of the house. I can't tell you about the internal functions. And the MRI is a very useful biomarker, but it's not all the things. And so we really would benefit in MS from better functional biomarkers. And we now have one, which is really cool. So let's talk about serum neurofilament light chain for a hot second, and then we'll talk about the Octave DA test. So when you have a neuron, which is the cell in the brain, and it's attacked, either because you get hit with a hammer or, God forbid, you have cancer, ALS, a stroke, MS, it breaks the neuron. And all the stuff in the neuron spills out. And the neuron's like a long fiber. And inside the fiber are chains. So there's a heavy chain and a medium chain and a light chain. These neurofilaments are called chains. So you have neurofilament light chain. The more neurofilament light chain that we find in the spinal fluid, the more damage the brain has suffered. And some of the neurofilament light chain in the spinal fluid leaks out into the bloodstream. And we've now gotten really good at drawing blood and measuring the amount of neurofilament light chain. So S stands for serum, blood, neurofilament light chain. So if you have a neurological condition and your neurofilament light chain goes up, that's typically bad. It means that whatever that condition is getting worse. And it's not unique to MS. It just tells you about like brain health, right? And so that's a biomarker. And there's a company called Octave. And they've developed a test which looks at 18 different biomarkers. Chief amongst them is serum neurofilament light chain. So there's serum neurofilament light chain and then a bunch of others, 17 others, including GFAP and all these other ones. And what they've proven is that when you pull them all together, they can add them all up in a special mathematical formula, and they come up with one single number called the DA test, the disease activity test. And if that Octave DA test is low, that's a biomarker that things with MS tend to be doing okay. In specific, the risk of attack or new MRI lesions is lower. If it's medium or high, that's a biomarker suggesting that something ain't right at a Circle K, and that there's a higher correlation with new MRI activity or attacks. It's not gospel from up on high, but it's a really cool biomarker because it's just a blood test. Now, it's been scientifically proven to Dr. B's satisfaction. When they first came out with this, I actually didn't want to be involved with it because they hadn't done the science yet, and so I didn't know if it was real. And they've now done the work, and they've published some very beautiful papers, and they've proven that's the real deal Holyfield. Unfortunately, it's not covered by insurance very well yet. Now, the company, and it's a for-profit company, right, that makes this test, they have a sliding scale. So based on the income of the family, they'll reduce the cost to make it affordable for some families. So the most you pay is like $300, which is very lot. And some people pay no dollars, right? And if it was covered by insurance all over the place, I'd get it 4 times a year in all my patients because I think it's that useful. I would like that information. Presently at the Boster Center for MS, we don't get it routinely because most of my patients don't have that kind of funds. But I'm very, very excited. And I do think in the next couple of years, insurance will figure out the value of this biomarker and they'll make it commercially available. Now, real quick before we wrap up, the question was, how does the DA test compare to neurofilament light chain by itself? The DA test is more informative than just serum neurofilament light chain. So by doing all 18 tests together, you have a better predictive value than if you just do serum neurofilament light chain.
So this being used as a biomarker, how far have they come, Octave being, how far have they come along to know a person's worsening over the next few months versus the next few years?
I don't know the answer to that. I don't know that they can make that kind of prediction just yet.
Okay, thank you. Anybody have a question? Going, ooh, talk about
All the way in the
holdout,
back, man.
right?
All the way in the back.
Talk
Giddy up.
about a holdout.
A follow-up to the question on the neuro light filament, would that be a replacement for an MRI or a supplement to an MRI?
So that's a great question. So it would be really cool if it could decrease the number of MRIs we need to get. So my hypothesis is that if I had that available 4 times a year, I might not need to get an MRI every year. I might, if it was stable, be able to do an MRI slightly less often. That's a hypothesis that I haven't tested, but that's my thought, is that maybe if I saw that your neurofilament light chain, or excuse me, your DA test was stable like Mabel, maybe I could avoid getting an annual MRI as frequently. Maybe I'd get it every other year. More to come.
Thank you very much. I want everybody to know that the last 4 times we've done a program, this guy has shown up with a sweatshirt. So today I wear a jacket and now you're in a sport jacket. That's very good.
Yeah, change it up.
Very good. All right. Thank you, everybody. Thanks for being here. Have a great night.